Been talking about the delightful topic of the anal canal. Remember, the anal canal is distal to that puborectalis muscle. Here's that puborectalis muscle here. You can see the conformational change that it's inducing on the rectum. And we're saying that below that is pretty much the anal canal. By the way, that puborectalis sort of merges with the external anal sphincter. Now, we'll talk more about the sphincter in physiology. But remember, you have the same thing in the urethra. When you need to urinate, the bladder distends, and basically that's going to cause an autonomic pathway, an autonomic reflex. That's going to cause the internal urethral sphincter to relax. And so that could be very socially embarrassing were it not for what? You have a backup. The external sphincter, which is voluntary, and that prevents, under normal circumstances, the CNS override prevents the reflex from necessarily determining your behavior. Same thing here. So you can delay elimination if necessary, if you find it inconvenient during class. Then whatever is in the rectum can be pushed back into the colon, and you can just wait for a better time and set of circumstances.
Up to a point.
But in any case, we'll talk more about that in physiology. Right now, I just want you to be aware that this puborectalis serves a number of important functions anatomically. It normally induces this flexure in both males and females, and it also sort of merges with the external sphincter anatomically, especially superiorly. The terms that you see down here are just alternate terms for the peritoneal lining, the peritoneal wall, the rectouterine pouch, rectovesical septum. Well, that's the pouch. So just be aware that in the medical literature especially, you see references to septum, but it really means the same thing. We're looking at the blood supply to the rectum here, and there are three rectal arteries: superior, middle, and inferior. Superior, middle, and inferior. We've seen this division of labor before. Superior from the IMA, the inferior mesenteric. The middle from the inferior vesicle, and also there's another source there, but we won't worry about that. The inferior vesicle implying what? The bladder. These are the uterine arteries that we're talking about there. And then the inferior rectal arteries receive their blood, that is to say, way down here from the pudendum. So all makes sense, follows that same pattern we saw before. In this illustration, they're also showing us hemorrhoids. I'll leave that to your clinical work, but oftentimes it's the venous drainage down here that gets caught up with hemorrhoids, and those that are below that pectinate line tend to be more bothersome, more of a problem. And then we can see the middle rectal artery, the superior rectal artery, and the cadaver preparation here. I think we already talked about this. I just wanted you to be aware that superiorly the innervation is predominantly sympathetic. Then, as we move inferiorly toward the pectinate or the anorectal line, there is a hybrid innervation of the rectum involving both divisions of the ANS. And then, as we get down here below the pectinate line, somatic sensation, pudendal branches of the pudendal nerve again, the rectal nerves. See the cadaver illustration of the anal canal. But what I really want to focus on now is talk a little bit more about the anatomical importance of this pectinate line, or it goes by a variety of names. We're going to be talking about this. We've indicated, for example, that one of the things that happens here is that the epithelium changes. It goes from a columnar epithelium to a squamous epithelium, rather inverting the Z line that we encountered before. and that's the reference here. We've already talked about the fact that these are primarily autonomically innervated mucus glands. And we've already talked about the blood supply, so that's just a repetition of that, and drawing a probably cadaver image. Here we can see the venous plexus, something pleasant to contemplate at lunch today. And again, that's the region that is most prone. And you can encounter it in individuals that spend a lot of time sitting, motorcyclists, horseback riders, all have usual typical issues. All right, very important slide here. Make sure you emphasize this one because this sort of summarizes some of the changes we talked about. So here's our pectinid line again, and what that refers to. We've already talked about the transition in epithelium, but in addition, notice the following. Right? You can pretty much just derive it all from this illustration. Blood supply above the pectinid line, it's chiefly from the IMA. Below the pectinid line, it's from the iliac artery. That's blood supply. Drainage, venous drainage, above the pectinid line, into the GI tract system, into the portal venous system. We talked about all that blood going back into the liver, for example. But below it, it goes into the general circulation, into the cable venous system, so it just empties into the general venous drainage. The nerves we've already talked about, largely autonomic above, somatic below, pudendal below, pelvic plexus above. So it's a very interesting anatomical division here. So keep those three in mind in addition to the epithelial transition we talked about. Now much of the rest of this I think we've already discussed. We talked about reproductive components in the physiology course. You know the anatomy, for example, of the testes, epididymides, and vas deferens, and so on. You have no trouble identifying the various components that you see here. This particular slide is focusing on the seminal glands. And again, be sure that you don't confuse the ampulla of the vas deferens, with this, which is what I just highlighted there, with the seminal vesicle here. The blood supply to the seminal glands is chiefly from the middle rectal artery and the inferior vesical artery. And we've seen this image several times already. So for example, if I were to ask you, what is the origin of the umbilical artery, what would you tell me? What is the origin? By the way, notice it's misspelled here. How should it be spelled? CAL, yeah. This would be an intracellular creature of some sort. So where do all these come from? The internal iliac. So again, and so you can see that the prostate is going to be perfused by the umbilical and the vesical arteries. The prostatic artery down here, again, portions of the vesical artery, and the seminal gland here, again, portions of the vesical artery. So you can see the ejaculatory duct at the prostate. By the way, in that illustration, it's not very clear here, but here's our perineal membrane, and they're sort of showing this disc here, but those are the Cowper's glands in that membrane, and then here's that portion of the male external sphincter. So all of that sort of in that space between the inferior perineal membrane and the pelvic diaphragm, which they sort of show here, right? That's that disc that they insist upon showing, and this is the pelvic diaphragm here. The prostate, I think we've talked about this, the apex at the bottom, base at the top. You have remember we have a prostatic urethra, which there's a little valve here, and then there's another little valve down here at the membranous urethra. And this you can cross out because this is antiquated terminology. In the medical literature, they no longer refer to lobes of the prostate gland. What you will learn when you study benign prostate hypertrophy and prostate cancer is this zonal system that is largely based upon radiographic images. There's a peripheral zone, which is, as the term suggests, peripheral to the central, but it's also inferior. And perhaps worth noting even in here that seems to be the source or the locus of most tumors. Most cancer seems to arise in the peripheral zone for reasons that, as far as I know, are not entirely clear. But of course, here's the rectum back here, so that when the physician is palpating the prostate, they're for the most part palpating the peripheral region, peripheral zone of the prostate. And so, as we've indicated, the prostate, chiefly from the vesical artery, giving rise to the prostatic arteries that in turn arise from the internal iliac. And then there's the extensive prostatic plexus that drains the prostate. And again, the men just have the willies looking at this, but here's the digital exam for the prostate. Of course, when the prostate enlarges for whatever reason, it not only can alter urethral function, micturition, but it can affect sexual function because of the convergence here. Also, it also compress the rectum too. That's not uncommon, and there are often symptoms arising from that as well. Tends to become, with the hypertrophy and cancer, become firmer as well. We talked about the Cowper glands that release the initial seminal fluid prior to the secretions of the other accessory glands, sort of cleaning the way, but small glands located in that membranous urethra. And I'm not sure this is very important. The structure is innervated by the sympathetic fibers and parasympathetic fibers. Part of what this is saying is that, as we've already talked about, arousal, for example, in the male, and some of the secretory functions are primarily sympathetic, call it sympathetic tone, but there is, for example, parasympathetic involvement with respect to arousal, sympathetic with respect to emission in some components of ejaculation. We've already made this point before. I think I've made it twice already, so we don't need to talk about this. This is just talking about the innervation of the male testes. Again, what we're looking at here is usually a periarterial plexus around what artery? Yeah, the gonadal or testicular artery. And we talked about the contents of the spermatic cord. I think you've already been through this in the physiology. You can see the general concentric arrangement. There's the spermatic fascia here. Then you have the cremaster muscle and the fascia there. The cremaster is kind of interesting in that it is skeletal muscle over which you have relatively little control, although there are some individuals and there are certain reflex responses where it seems to respond to voluntary action or command. And then interiorly, we're looking at the pampiniform plexus we talked about before, and then the testicular artery. You can see that cremaster, again, has a variety of appearances, highly diverse. The muscle that you sort of see in strands here is contained within the fascia, and we've already talked about the function important in maintaining the testes at the correct distance from the abdominopelvic cavity. By the way, one of the more complex aspects, we go back to this illustration, is that about all I would have you know is that innervation to the tissue arises from the lumbosacral plexus. As you see, it's very messy up in here. So as we come back to this slide, let's just say it's lumbosacral. Be able to differentiate, as you had to do in the reproductive unit, between the cremaster muscle and the dartus muscle. Dartus muscle is contained within that dartus fascia, which is one of the superficial fascias. Remember, the dartus muscle in human males is one of the, possibly the only smooth muscle that extends to the integument and can actually change the tonus of the integument once again for the purpose of conserving heat. The only thing I would add to our previous discussion of testicular anatomy is be aware of the membranes here. This blue, or this septal covering that you see here, is called the tunica albuginea. Tunica albuginea, which will continue into the male penis. And then surrounding the tunica albuginea is this large sort of peritoneal lining called the tunica vaginalis. And you can see it has a visceral and parietal layer, but they're connected. They're actually just one membrane. And then there's some serous fluid in here to keep them from adhering. We've already talked about the anatomical components of the testes. We've talked about the testicular arteries, the pampiniform plexus. Lymphatic drainage is generally to the groin, the inguinal nodes, and then eventually to the aortic, what are usually called pre-aortic nodes, just in the same way that you learned about prevertebral ganglia. These lymphatic nodes are usually called pre-aortic, but the drainage is generally in that direction. And by the way, you can also see that periarterial plexus here running along the gonadal artery. Mm-hmm. You know the organization of the epididymis, you know the function of the epididymis. We talked about that in the reproductive unit. Again, another unpleasant subject for males, as males tend to be more prone to this particular problem, inguinal hernias. There are two general classes of inguinal hernia in males, indirect and direct, and you can see what's happening. We're looking at the indirect hernia here, and here's where the bowels, the intestine, have actually been extruded into the spermatic cord. There's displacement not only of the peritoneum, but the transversalis fascia into the spermatic cord, and so yeah, that can be fairly serious. This is more common. This is more likely to be present at birth, and it's usually called the direct or the congenital herniation. And the main difference, at least anatomically, is that notice that the indirect is lateral to the epigastrix. The herniation of the bowels into the transversalis in the direct is medial to the epigastrix. You will learn to palpate for this in what's called the Hesselbach, or the inguinal triangle. And you can see this little region here is called the superficial inguinal ring. And you can see, I just cringe at the prospect there, but you can see the individual palpating that region at that inguinal ring. But this whole yellow region is called the Hesselbach triangle here. You can see another illustration of it there. Framed by the rectus muscle, the inguinal ligament, and the epigastric. See anything? We've already looked at the cross section of the penis. Notice that we have again the erectile tissue, the corpora cavernosa, The deep arteries, both the deep arteries and the dorsal arteries, are both the branches of the pudendal artery that came down the pudendal canal. This is the continuation of the tunica albuginea. So number 4. And then exterior to that is what's sometimes called the superficial fascia or Buck's fascia. Don't think there's anything here. We talked about both the male and the female. The clitoris and the penis also have a glans at the terminus. The male has the raphe that extends all the way along the shaft and base of the penis. And then, again, most of the structures are analogous. Again, this is one I added a few days ago because I wanted you to see that. Remember, we saw the image of the bulbospongiosis at the base of the bulbospongiosis in the female, sort of surrounding the vestibule, and the vulva in the male. Notice it's only the inferior margin of the base or the root of the penis that is enshrouded or encapsulated by the bulbospongiosis muscle, which again is this muscle. And you can see there's a midline tendinous region right here where the two halves come together. Otherwise, the rest of this should be very familiar to you. Here's our transverse perineum and then our levator ani back here. Here's the anal sphincter interior to that. So in the illustration here, here's the pudendal artery back here, and that's going to branch into these vessels, and you can see one is going to be the deep and one is going to be the dorsal, but they both arise from the same perineal artery, which is right here, a branch of the pudendal artery. We've already talked about the fact that arousal and erection, for the most part, is parasympathetic. Emission is, at least in part, sympathetic. That both, erection in any case, in both the male and the female, involve the diversion of blood into those cavernous tissues where the veins are restricted and the blood is not allowed to escape until the relaxation occurs. We've already indicated that nitric oxide is often involved in triggering that response. And remember, we talked about in the physiology the arteriovenous bypasses. This is a classic example of here where blood is diverted from those bypasses into the hilocene arteries for engorgement to occur, again, in both the male and the female. We talked about the external male structures. We're looking at the female structures, at least a portion of them here. You should be familiar with the anterior mons pubis, generally a fatty region, fatty tissue. The labia majora and the labia minora, majora out here, minora forming the margins of the vestibule. As we saw, the clitoris is often misunderstood. I'm sure women would agree by males in that all of this is clitoral tissue. So the clitoral tissue has two, sort of a crus region like this, and then you can't really tell from this illustration, but it extends like a hook anteriorly or inferiorly. So it's very analogous to the male, at least this portion is very analogous to the male structure. And then when we talked about the erectile tissue in the female, it's important to understand that all of this tissue is cavernous, including the bulbs down here. So all that is erectile tissue. So if I missed anything up here. There's reference to a couple of different types of glands. You don't see them all that clearly in this illustration. Let me just conclude with this. So the region between the labia minora, again, is typically called the vestibule. The entire apparatus, the labia majora, is usually called the vulva, including all of the components that we see there. We can see that bulbospongiosus muscle that we saw in the male, sort of extending around the, sort of almost like an orbicularis muscle around the vestibular region. So see, there are reference to a couple of glands here. This illustration is not so great, so let me turn to this one. We've already talked about the Bartholin's glands. These are also called the greater vestibular glands. These secrete mucus adjacent to the vaginal orifice here. You can sort of see the openings there. So those are glands that are analogous to the Cowper's glands. But also in the female, and a topic of considerable controversy, and I've never seen it debated in the past 10 years, 10, 15 years, are those two little openings adjacent to the urethra called the paraurethral ducts, and they terminate at what's called the Skene glands, or Skene's glands, sometimes the lesser vestibular glands. And the Skene's gland, SK, it's probably in there somewhere, Skene or Skene's glands, they are analogous to the male prostate. In fact, they secrete even the prostatic antigens. And there's a whole lot of speculation about their function, but probably best reserved for another course. In any case, these glands are sometimes called the male prostate. I'm sorry, the female prostate. All right, that's about all I can think of. Any questions about any of that? If not, why don't we take a long lunch and we'll reconvene then and again, I thank you for your very, very kind, I'll be touched. You're probably sobbing in my office. So. Oh, sure.